I would like to welcome Dr. Partha Shetty with over 2 decades of experience in the field of nephrology. He was trained in the prestigious KEM Hospital in Mumbai and did his transplant fellowship in Ottawa, Canada. With further ado, Dr. Partha, please continue with your talk on the recent advances in kidney disease.
Thank you, Professor Shank. Shank is my colleague in Perth Hospital, and we are the same team there. Uh, he is on close friend of mine too. So I'll be talking to you briefly about protection of the kidneys and diabetes and what we can do about it. A lot of data here, but I will try to make it as simple as I can. So as you all know, India has the world's highest, second highest kidney burden. Highest is China at 152 million, and India at about 38 million, and approximately around 11.5% of Indians are diabetic. So compared to the US, which is 0.5% of diabetes, we are almost twice to increase diabetes compared to US. So over here, the overall disease for diabetes is tropical in India among the type 2 diabetes is about 44%. That is probably because unlike type 1 diabetes, where you actually have many years of evolution of the complication of diabetes, about 30% of the type 2 diabetics have diagnosis itself of diabetes have a nephropathy. South Indians show a higher prevalence of the nephropathy, and that is genetic and also because of visceral fat. So, like we know, we have the thin fat issue where you have thin Asians who have visceral fat around the visceral organs and ectopic fat hidden in the liver and in the pancreas. So they are more prone to having diabetes, dyslipidemia, and hypertension. This is called the KDIGO heat map for CKD. So this is been designed by Goinger, Ingelheim, and KDIGO. KDIGO is a body like the AHA or like the ADA, which has a non-profitable work group for kidney outcome diseases. So on the x-axis over here, we see the proteinuria, which is divided into A1, A2, and A3. That is normal to mildly increased. That's less than 30 milligram per gram. And A2 is moderately increased, which is earlier called microalbuminuria. And A3OZ is severely increased kidneyuria. And along the Y, we have G1, G2, G3, G3B, G4, and G5. That's the same thing as the stages of CKD. So we have the GFR more than 90, and as the stages go up, the GFR keeps reducing. So if you look at it over here, we take the green color as low risk, we take the orange, yellow as the moderate risk, we take orange as the high risk, and we take light and dark red as the high risk. So for example, if you have a GFR of more than 90 or between 60 and 89, and if you have protein levels in the urine less than 30 milligram per gram creatinine, you would still be having a low risk. And if you have a GFR which is below 30, and if you have a proteinuria of more than 300 milligrams, you will be having a very high risk. That's how we stratify the risk. And they also have in the KDIGO suggested when we can screen and when we can treat and when we can refer. That depends upon individual practice. The main parameters to look into and monitor in diabetes for a physician will be albuminuria, the GFR, the trend of the same. Look for other causes of proteinuria and loss of GFR. And the golden question is the kidney biopsy. Now, when to do it? So, if you have a person having type 1 diabetes for many, many years with PDR, then you probably could safely assume that the nephropathy is because of diabetes. But even in diabetes type 1, if you have people having a rapidly increasing proteinuria, maybe doubling or tripling of the protein within 6 months, or if the creatinine is rising progressively, you would think of a non-diabetic glomerular disease. Whereas in type 2 diabetes, since 30% of them already have proteinuria or abnormal creatinine presentation, I keep very low thresholds. If you have got a low and stable creatinine, and if you have proteinuria subnephrotic below 3 grams per day, and if you have very severe proliferative DR, then you could probably assume that is because of the diabetes. But if you have lesser retinopathy like an NPDR, or if you have nephrotic proteinuria, or doubling of proteinuria, or dropping GFR, raising creatinine, you would do a biopsy. The reason being that if you have something that's non-diabetic, so approximately 40% being non-diabetic, out of which 80% of them can be actually cured or halted or retarded in terms of progression. And if you miss that, assuming it is diabetic, you will actually end up losing GFR and having proteinuria, which would probably be very, very significant. How do you define DKD? It's defined with the presence for at least 3 months of increased urinary albumin excretion or reduced GFR. And the question every patient is going to ask you is, can we reverse the diabetic nephropathy? Evidence shows that regression of, this is actually from the journal which I will quote, regression of moderately increased or A2 albuminuria to normal is common in patients with type 1 diabetes and may occur more frequently than progression to severely increased or A3. So very often we see in this KDIGO heat map that people have actually moved categories from orange to yellow or from yellow to green. Moving from the reds is difficult because they already have lost GFR and that is difficult to reverse. Also, as per these journals quoted over here, frequent regression of microalbuminuria in patients with type 1 diabetes indicates that elevated urinary albumin excretion does not imply inexorably progressive nephropathy. In addition, regression of severely increased A3 albuminuria to moderately increased or A2 albumin can occur in both type 1 and type 2 diabetics. And smaller studies involving type 2 diabetes have reported 36 to 48% regressed from severely increased A3 to moderately increased A2, and that 2 to 13% even regress back to normal. General measures, obviously, for retarding the progression of the nephropathy or even reversing in the early stages would be strict glycemic control. So, as you all know better than me, we take 7 as a good A1C, but KDIGO recommends even 6.5 for the early stages of CKD. Hypertension controlling is very, very important because of the direct increase in the capillary pressure. So 130/80 will be the target for people having proteinuria and nephropathy. Modification of lifestyles, exercise, weight loss, smoking cessation. And role of statins. Statins are known to have a curative action. So apart from the cardiac protection, they also help with proteinuria and with GFR decline. There are some studies, of course, indicating that in mice predominantly, if you have statins given for a long duration, you can end up having pre-diabetes. But then that is, in human studies, there are very, very limited data on that. So we do give statins. What are the targeted measures for DKD? So we have a whole plethora of drugs here, ACE inhibitors and ARB, combinations of AC and ARB, SGLT2 inhibitors, GLP-1 agonists, and non-steroidal MRAs like fenvenone. Now, I must tell you all that the combination of AC and ARB for people having proteinuria or abnormal GFR is not used anymore. We have this huge trial called the on-target trial where we use telmisartan in combination with the ACE inhibitors, and they actually prove that by giving combination of the drugs, there's a higher hyperkalemia and GFR loss, and they even aborted the trial. So combinations have no role of AC and ARB. AC and ARB significant trials with the collaborative study which had in 1993, captopril versus placebo, and the study was for proteinuria benefits. And this was in type 1 diabetics. Then we had the IDNT with irbesartan, and we had the renal study, which involved only type 2 diabetics. And if you compare the collaborative and the renal studies, collaborative was more of type 1 diabetics, renal was predominantly type 2 diabetics. Sample size 409 versus 1513. Primary endpoints were doubling of serum creatinine in the collaborative study with captopril versus composite endpoints of doubling of creatinine, dialysis, and death in the renal using losartan. And they showed that captopril over the span of 3 years had a 48% reduction in the doubling of serum creatinine, whereas the renal with losartan had only 16%. The reason why we had 48% was because the study which involved captopril involved people having milder proteinuria and younger people, and they were looking only at doubling of the creatinine. Whereas, if we look at the renal study involving losartan, we look at all 3 things. The patients were older, they were type 2 diabetics, and we are looking at not only the creatinine but also the dialysis and the death factor. So if you look at the drugs per se, there is no inferiority between AC and the ARB. IDNT, the twist was they put a calcium channel blocker into the study. They put Norvasc, amlodipine, and that showed that independent of BP reduction, the amlodipine arm showed no benefit compared to the placebo arm. So it was all about the irbesartan itself. 35% reduction in proteinuria losartan and 33% with irbesartan. Coming to the SGLT2 inhibitors, there's a lot of noise about these drugs today. We have three major trials: the Credence, which use canagliflozin, the DAPA-CKD using dapagliflozin, and the EMPA-CKD. There were some very significant differences in these trials, which you all probably know. The first being that the Credence was the oldest trial in 2019, and that was only for diabetic patients, right? And the DAPA-CKD, which came out in 2021, the data had 67% diabetics, and they also had a non-diabetic population consisting of other GLOM diseases and IgA nephropathy. And the EMPA-CKD, which was empagliflozin, had actually more of non-diabetics than diabetics. And the main difference was the EMPA-CKD trial also had people having a low GFR. So if you look at the Credence and the DAPA using canagliflozin and dapagliflozin, for those patients the GFR was averaging around 40, whereas in EMPA-CKD they had a larger number of people. It's a more recent trial using empagliflozin, and here they had GFR up to 20 also. So what they showed is, if you look at the primary composite outcome, that is of ESRD, doubling of serum creatinine, and death in the Credence trial with canagliflozin, and if you look at the composite outcome at the dapagliflozin trial, that is more than 50% GFR loss, ESRD, and death. And if you look at the EMPA-CKD trial, which shows more than 40% GFR loss, ESRD, and death, the reduction of primary risk was 30% in the Credence with canagliflozin, 39% in dapagliflozin, and 28% with empagliflozin. The all-cause mortality was significant only for dapagliflozin and not for the canagliflozin and the empagliflozin. So these trials actually proved that there was a significant reduction in the primary outcomes using these SGLT2 inhibitors. So what we practice in nephrology is anybody having proteinuria, anybody having a GFR more than 20 should be on a gliflozin for both their cardiac benefit and their renal benefit. There's not much of a problem using these drugs also. There's a 2% risk of urinary infection, and if you have somebody having recurrent UTIs, you can always stop the molecule and you can treat them and you can challenge them again. Another major drug was the GLP-1 agonist. So we had this major trial called the FLOW trial using semaglutide versus placebo. They increased the dose slowly from 0.25 milligrams per week over 4 weeks to 0.5 for 4 weeks and then 1 milligram. Duration was 3.4 years, and they actually showed a composite onset of kidney failure, 50% reduction in GFR from baseline, and death from both renal and cardiac causes was 18% compared to 23% in the placebo group, with a p-value of less than 0.0003. So these drugs, to be honest, I don't use without a physician following up because I practice core nephrology. But they have shown to be of great use in the obese population and those who have got insulin-dependent diabetes. The last drug I'll talk about today, which has made a lot of noise again, is Renoprotection. A little tricky drug to use because of the hyperkalemia, so you got to follow a patient really carefully. So they had this huge study involving 30,000 people for the Fidelity. It was a food analysis of two other trials called Fidelio and Figaro. All these patients were already getting a good dose of an ARB. So what they recommend for diabetic proteinuria and GFR is what to use in a combination with an ARB. We in nephrology use proteinuria for other diseases also. The data are still inadequate, but in diabetics it's preferred to be used with an ARB. So all these data is with an ARB. And Fidelio was mainly for CKD with low eGFR, and Figaro was more for proteinuria and better GFR, and they pooled both these data. And the primary renal and cardiac endpoints did make a difference because the Fidelio was looking more at the kidney endpoints because GFR was low, and secondarily the cardiac endpoints, and Figaro was more of cardiac endpoints and secondary renal endpoints. And what they showed in this combined analysis, there was, if you compare the 40% loss of eGFR from baseline, progression of end-stage kidney disease, and hospitalization due to heart failure and death, there was a 14% relative risk in cardiovascular outcomes and 23% relative risk in the renal outcomes. And there was also a reduction in the UACR significantly at the end of 1 month, as early as 1 month, and at 3 months also. So these drugs are absolutely warranted in people having a GFR of more than 20. in combination with ARB. The issue of hyperkalemia, yes, potassium is more than 5. We usually stop the phenomenon, continue only the ARB, and we monitor patients at least every monthly for the first 3 months. How to choose? If you have cardiac failure, you will use an SGLT2 for people having heart failure with reduced ejection fraction, with moderate ejection fraction, and for having even bigger ejection fraction. Although the data does show that if you have LVEF below 40, spironolactone is a better drug compared to finerenone. Without cardiac failure and with pre-existing atherosclerotic CVD, you can choose between SGLT2 versus GLP based on the patient profile. So if you're having a obese patient or somebody having insulin-dependent diabetes, you would probably prefer a GLP compared to an SGLT. Without cardiac failure or without atherosclerotic CVD, if ACR is less than 30, we use an AC or an ARB with the SGLT. And if ACR is more than 30, we use a SGLT or GLP or finerenone. The reason why I've given options over here, not the combined drugs, is because we don't have any trials which are comparing the individual agents head-on or a combination. But then we often use a combination of drugs. Yeah, that is the end of it.
Dr. Partha, that was a very good talk. You covered the entire nephrology almost. What we are seeing is like no, most of the diabetic patients, we always screen only for the sugars and the blood pressure, maybe cholesterol. And this is an asymptomatic disease. When it progresses, because usually we screen the creatinine or we get a spot microalbumin or only an albumin, which always misleads us in the initial phase where the creatinine is much normal. So what is your screening for like no general population of diabetic patients? What you will recommend?
Yes, so all diabetics, all hypertensives need a yearly screen for the urine albumin creatinine ratio and for the GFR, the creatinine test, whether they are irrespective of their diabetic status. And if these reports come abnormal, then depending on the level, we decide as to how often they must come back at CF. But the yearly retina screen and the creatinine and the urine CF is mandatory.
I think the retina will be a better way we can at least identify like no
Yes.
some
It usually correlates.
micro vascular complication is going
Okay.
on.
Dr. Partha, I just want to know, you follow a stepped approach in adding medications because current guidelines they add everything together.
Yeah. So there are data regarding that also that's being published, which shows that they prefer adding everything together because there is no clarity as to how frequently to escalate and when you should add a second drug. Especially people who are very moderate, who have got reduced EF, people who have severe proteinuria or moderate proteinuria retinopathy. The data shows that if you wait for a stepped approach, you actually end up losing GFR and worsening proteinuria. So many people add drugs together, but they monitor carefully.
Any questions? Anybody wants?
Regarding dosage of ACE and ARB in patients with CKD, do we reduce or any particular optimal full normal dose like normal patients for you, or
Yeah,
do we reduce the dose?
so we actually start with lower doses and go up, but we don't reduce unless the GFR drops or we have hyperkalemia. So if you're having somebody taking telmisartan 80 mg, if the creatinine is stable and the potassium is below 5.5, I would continue the same dose and not reduce it. I would probably, if it goes up, potassium goes up, I would decrease the dietary potassium, I would use a potassium binder, I would give some Lasix, control sugars better, but not reduce unless you have a problem. Yes, ma'am. Prefer continuing it, ma'am. The thing is, we should at least have the ARB on board. It's an expensive molecule, even if you use a cheaper molecule like one of the generic molecules like Livelsa, for example, we are still spending a fair bit of money. And if you use to get India, then obviously it's really expensive. Stopping the molecule of less benefit would not be something we suggest to do. But yes, at least if not known, at least an ARV at a good dose. Yes, it's a long-term drug. No, no, they wouldn't. It's a long-term drug. Yeah. And unlike spironolactone, even the half-life is only 2 to 3 hours. Because spironolactone metabolite, the effect will persist for 24 to 48 hours. It's a known short-acting drug. So if you stop it, it's going to stop acting almost immediately. It's really expensive.
No further questions. I think we can conclude. Thank you, Dr.
Thank you,
Partha.
sir. Thank you.
We have been having this silent hall. So here you can switch over to the hall A because the light in this one is red for hall B. And if you can switch over to green color, you can get into hall A, which is again displayed in the TV monitor.
Speaker and chairpersons, I request you to please get your pictures and mementos.